Thank you for the kind invitation and for the long cooperation with the Earthly Company. Hello everybody, or as we say in the Netherlands, goedemiddag. We want to have was it the right pronunciation? I don't know. I have to learn a little bit more about the Netherlands. So I'm very glad to hold a presentation now after 2 years of webinars only online. I hated to look into a screen. I have to look in the camera as well, but I see a couple of friendly people listening to my presentation. I'm very glad to do this at the moment. So we want to talk about glaucoma surgery and especially about the HFDS, minimal invasive glaucoma surgery approach from Earthly Company. That was glaucoma surgery, and so you see I'm an old guy. That was glaucoma surgery as I started. We had medications, we had on the other end trabeculectomy, we started with canaloplasty and with deep sclerectomy. Today it's completely different, so we filled this gap between medication, trap and tube shunts with a huge number of different surgical approaches. The question is there an approach which fits for every patient? In my opinion, no. That's why there is a number of different surgical approaches, and we will talk about today about the HFDS, high frequency deep sclerectomy, offered by Earthly. It's an approach which addresses the trabecular meshwork. So we have different MIGS approaches, as you see here in an overview. We have a subconjunctival approach as known from Zen or PraserFlow. We can endlessly discuss is PraserFlow minimal invasive or not. So we have Schlemm canal trabecular meshwork, and that is the region which addresses HFDS as well. And we have the supraciliary space. There is no implant at the moment available. The former implant we used was a Cypos, but because of safety issues is withdrawal from the market. So how about outflow resistance? And let's have a closer look into Schlemm's canal as shown here. Schlemm's canal is not only a tube. We have cylindrical structures which may increase the outflow resistance. Not only trabecular meshwork has its own outflow resistance. And we have the collector channels, which shows hinge-like valve mechanisms which also can block, and if we are able to open this, it would lower outflow resistance as well. So if you see there are more than one mechanism that can rise up outflow resistance. So HFDS a new kid on the block? No, it isn't. So the first publication, as you see in here, 2006 in Graves Archive, by Bojan Pajic, and he published in 2006 his 24 months results. So it's nearly as same as old as the better known trabectome. And if you remember the results presented in the first publication, they are really similar to that what we achieved with the trabectome as well, but with a less technical approach. So you see in the trabectome we always need a second surgical device to drive these MIGS approach. So and now we have an overview about different approaches. Well known the family of the iStent. The last introduction was the iStent W. The Hydrus was a couple of months introduced into the European market. And these are the addressing trabecular outflow, but these are all implants. We have the Cypos, the iStent Supra, the Mini-Jack. All of them are not available at the moment of the market, approaching supracortical outflow, and we have the Zen and PraserFlow addressing subconjunctival outflow. Another product not on the European market available, but in the States at the moment, I think it's an interesting solution, but a complete different approach. It's a slow release device, an implant we put in the anterior chamber, known under the name Durista, that is Bimatoprost implantable in the way we know from the Ozurdex implantat. It's the same injector system, but we put it in the anterior chamber. But at the moment, it's only approved by the FDA in the United States for one administration only. So, but what is the difference to HFDS? It's always, we put an implant in the structure, in the anterior chamber or subconjunctival, or we put some material into anterior chamber. And that is the difference to HFDS. What we do here is, we have these, I don't want to call it simple, but easy and sophisticated tip, which opens trabecular meshwork and creates a scleral pocket. And if we are lucky enough, we address it to a collector channel, and so we are able to reduce trabecular meshwork outflow resistance. We are able to reduce resistance inside the Schlemm's canal and as well of the collector channels. The treatment will be done not because of the surgical approach. The surgical approach is from temporal, and we do 6 of these pockets in the nasal quadrant, where the majority of the collector channels is mostly located. So the idea is not a coagulation, but with these HFDS we do a vaporization of the tissue. That's why we create a pocket, so we don't burn the tissue. That is the difference between a coagulation and that what we do with HFDS. So because the temperature on the tip is much higher, that induces 100 degrees. If you are fine with physics, we know water starts boiling at 100 degrees. So you see these bubbles during the video. I will show you live. So, and we induce a light arc, and that vaporizes the tissue. So there is no tissue remaining, and there is no burnt tissue. And burnt tissue, on the other hand, means there is a scarring. So that is an animation. Shows how it should work. It was done and introduced by Bojan Pajic with his direct gonioscope. So today we do it mostly with a gonio prism. So that's the way it should look like, and that is a case of mine. I prefer to use these Volt gonio prism because you're able to stabilize the eye with these fixation ring, and you have these floating prism which doesn't adds additional pressure on the cornea. So address the trabecular meshwork, the border between the pigmented and non-pigmented trabecular meshwork, not too deep, otherwise you will cause a distortion of the pupil, and that is the effect. You see these light arc, little lightning, and on the other hand, before you start with the surgery, there is important of a proper filling with a viscoelastic. So, and then you see nothing, no bleeding. But what you see, I've elevated the pressure during the surgery much higher than I do it probably with an eye stent. In an eye stent, I want to see some reflux bleeding. So here I have to be sure to identify the trabecular meshwork. There should be a pigmentation. If I can't see it, I lower it a little bit. I will have a look. If there's some blood, I see the trabecular meshwork, add a little bit of viscoelastic again to have a high pressure to prevent bleedings. And if you wash it out, you have seen some small reflux bleeding. So the risk, in my opinion, the risk of post-operative intraoperative bleeding is absolutely manageable. It's no risk. So, and that what happens in an OCT after wound healing. So you see it's not only an opening of trabecular meshwork, but there is a scleral pocket you induce. And that, if you are close to a collector channel, so you will reduce additionally outflow resistance. So it's not the primary aim of the procedure, because it's hard to find intraoperative if you have a steel a tip to identify beyond trabecular meshwork a collector channel. So you can find out the region before doing surgery on the slit lamp. You can see hopefully episcleral veins or collector channels, but they are intrascleral. So in a couple of cases you address it and you have an additional effect. The main effect is opening of trabecular meshwork and opening of Schlemm's canal. The pre-operative treatment, it's easy, there is no chains. no change needed. Post-op, it's quite the same as cataract surgery with a longer steroid application, and what I'm doing is myotics for about 2 weeks post-op to prevent anterior synechias in the trabecular meshwork region. But then there is no other change. I stop in all of my cases the IOP lowering medication after surgery completely. So I don't do an HFDS on a patient with 40 pressure and 4 medications. So the perfect patient is about 2 medications, a pressure of 20 up to 25, in my opinion. I do it mostly as a combined procedure, but under this condition, I think it's safe to stop intraocular pressure lowering medication immediately after surgery. So do we have some publication? Okay, that is the major issue in all mixed procedures. That what we are looking for is long-term data, and is data about hundreds and thousands procedures. So we don't have it at the moment, but there are still a lot of publications showing once the effect, showing as here a long-term effect, about 6 years. Now we're going to 8 years. Bojan Pajic will publish it over the next months, and we see in all of these publications, first of all, a safe procedure and an effective procedure. It doesn't lower the pressure from 40 to 10. It's not the aim, and we can't achieve it with any procedure we're doing in trabecular meshwork surgery. It's impossible. So, but it's effective if you see here from around 30 to 15 over not only 2 years but up to 6 years, as we say. And it works as standalone and in combination with cataract surgery as well, with the same results. The IOP lowering effect is between 25 and up to 40%, as seen here in a couple of publications. So the latest publication from Bojan Pajic, who is not only the inventor of these surgical technique, but also the guy who published the most data of this, was the IOP lowering effect measured with these triggerfish intraocular lenses to prove the concept of a lowering effect all over the day, the diurnal IOP. We know in most glaucoma patients we have pressure spikes over the day, over the night. It seems to be equalize these pressure spikes as well, which is a great message. If we compare it to other surgical techniques, here compared in combined surgery, we see that the number of or the IOP lowering effect seems to be higher than in an iStent or in Ky-hook dual blade or in ABIC procedure, in combination with cataract surgery, as well as the IOP, as the reduction of medication. So I think a wonderful message. Complications, as you have seen intraocular, there are no complications. So there are complications. Of course, I showed you my best video. So, and it took me a couple of efforts to do this. The most frequent intraoperative complication is an reflux bleeding, but that shows you have an Schlemm's canal which has a connection to collector channels, and if you're lowering the pressure, there will be a reflux bleeding. So, but if the patient is under anticoagulation, so there could be a hyphema at day 1 after surgery. In most of my cases, there is no additional or second surgery needed. Wait up to a week, and in all of my cases, the hyphema completely resolves spontaneously. The other thing is a temporary IOP elevation, mostly due to remaining viscoelastic in the anterior chamber. So if you see viscoelastic, cohesive viscoelastic at day 1 in the anterior chamber, and the pressure is really high, higher than 30, so then send the patient back to the OR, remove it. But in most cases, so 25 is fine for me, prevents an additional bleeding, and wait a week, introduce some IOP lowering medication for about a week, and that's fine. So, a late onset complication as described by Boy and Pyatt, so only cataract formation in phakic eyes. So, but if you are open once the anterior chamber, we all know we induce a cataract formation. So conclusions for me, a simple, effective op interno approach, one that fulfills the efforts and needs of MIGS very well. The difference to other surgical approaches in MIGS is it's implant-free. You don't leave anything. If you leave something, you have done something wrong. Maybe it was a tip, but the tip is too large to leave in the anterior chamber. And so, as we see from the literature and from my own perspective, it has a good safety profile. The post-op management is easy, comparable to cataract surgery, plus myotics for 2 weeks. It has a short learning curve. If you had it implanted and successfully implanted in an eye stand, you will be able to do an HFDS as well, and it is easy to combine with cataract surgery. Thank you for your attention, and if there are some questions, I'm here. So the question was, when do you do the HFDS procedure? Do you do it at the beginning or at the end if you combine it with cataract surgery? I do all these, not only HFDS but eye stand as well, at the end of the procedure. And especially for a beginner, I think it's much easier because you can deepen the anterior chamber, and that is very important, not to touch the peripheral iris. Otherwise you induce a distortion of the pupil. So, and at the end of the surgery, so my standard size, I'm working with an Earthly system, is 2.2 main incision in cataract surgery. So if you add some Helon, so the anterior chamber is completely stable. There is no risk of leakage in my hand, and that's why I would prefer to do it at the end of the procedure. So excellent question again. Can we use this procedure in neovascular glaucoma as well? I don't recommend this because, first of all, the cause of these glaucoma is completely different. It's not there is a second effect of neovascularization on the outflow resistance in the trabecular meshwork, but the cause is another. There is some vascular disease you have to treat, and then you can fix the glaucoma as well. On the other hand, if you do these, in my opinion, the risk of bleeding is much higher, and of repeated bleeding. Because what we do is, we open Schlemm's canal, and if the pressure is about 12 or above, there will be no reflux bleeding. But if you open neovascularization, so I'm not sure that they will heal immediately, and they can reopen and induce another bleeding. So don't do it. Thank you again for inviting me and to give me the chance to speak about HFDS, a promising effort to glaucoma surgery. Thank you, Thomas, and thank you to Earthly. Thank you to all of us. Thank you.